the common consulting areas that we tend to see. As you see here, even Tiger and Roger need a coach. And we all get into bad habits. And I even think that well-established GPs, supervisors, should occasionally probably have colleagues sit in and offer them advice about how they may be doing things in a slightly unusual way. But I would emphasize that if you are encouraging your registrars to sit in with you, try and produce some kind of focus. Christine Longman's work has researched this, and it's much more productive if you actually give them something to focus on, like how to set agendas, time management, so they're thinking, and also try and encourage them to give you feedback. That also really makes them sit up and concentrate. Now, the golden 60 seconds, as we all know, the mean time at which the doctor interrupts that opening statement is usually about 18 seconds. And there's a huge amount of evidence now that Cambridge Calgary document that the opening 60 seconds really is crucial in defining how the consult progresses. And if you look back at aberrant consultations where things have gone badly wrong, you can often see warning signs in the first 60 seconds. So not interrupting that opening statement. And most opening statements would end after about 45 seconds. If they go on for more than a minute or two, then it may be worth interrupting because it's pathological if a patient just talks and talks and talks for more than a couple of minutes. Next one, intrusive use of the computer. There I am sitting there, and there's the patient really thinking that they don't matter. So they talk about the third person in the room, and our registrars are now such good typists that they think they can sort of look at the patient and touch type at the same time, but they get a kind of automaton-like stare on their face. And it is not a good look. It's very, very difficult to create good rapport if they're actually typing. So I encourage them very strongly, yep, you can type a little bit later, but maybe please not in that first minute or two, because you need to spend that looking at the patient eye to eye, really engaging with them, offering sympathy, even with a look, if appropriate. And when it comes to sharing results, sharing the computer with them, not just you monopolizing it as I'm doing here, turning the screen their way, using the computer in a helpful way. Now, problems with rapport, what I mean by this is just those social bit of banter that established GPs, experienced GPs talk about the patient's suntan, whether they've been on holiday, things like that, that just smooths the whole running of the consult. And a lot of registrars say they don't feel they should or could ask about social things like that. And in a sense, we need to empower them, just to give them a license and tell them why it's so valuable. And Peter Tate's got a great quote, which is, do I know significantly more about this person as a human being than before they came through the door? And if the answer to that is yes, if you know their family, what jobs they do, where they've been on holiday, what hobbies they enjoy, things like that, then if you do know significantly more about the patient, you've probably been quite patient-centered. Not screening for other problems. Now, this is a common one, and they get caught out time and time again because they don't realize as registrars that the patient doesn't present the most important problem they've got first. That first problem is often not terribly important. And so screening for other problems early may help prevent the presentation later, the door handle presentation of something quite serious like a breast lump or chest pain. And there's good evidence that asking the question, is there something else, rather than is there anything else, is a better way, is a more discerning way of getting that most important thing out early. Having assessed that there are maybe 2, 3, maybe 4 problems that the patient would like to deal with, managing that agenda, trying to limit how many you try to cover in one 10 to 15 minute slot is a key skill. The registrars on the whole are too nice to the patients. They have difficulty with the patients who've taken a day off work just to come to the GP and they've stored up the 4 or 5 problems and they'd like them all dealt with today, please. And to empower the registrars to actually resist that a little bit and develop the ways of handling it. A very closed questioning style is a common error, and I see this, I teach at Monash, where if the role player has a pain, the Monash students have an acronym, I forget what it is, but it's got about 10 questions, and they go rat-a-tat with their questions, and not realizing, and some of the registrars obviously get it, and they realize the value of using open questions and tell me more, and anything else that you notice is much more time-saving. But some of them have this residual university undergraduate approach to taking a history. And there's this wonderful concept of building a history, a more collaborative way of building the history with the patient rather than taking the history and extracting it. Now, this is one of the big four performance criteria. This is one of the big four. And the Monash students, and I'm sure most of the undergraduate curriculum now, does include this part of taking the history. The trouble is that it's actually quite a difficult thing to elicit in a slick way. And if you just ask, what are your ideas, concerns and expectations, it's very, very clunky. And the registrars worry it's going to be turned around and sent back in their face. You're the doctor. That's why I've come to see you. And so it's all about helping them develop ways of eliciting this information in a way that seems supportive, and by maybe prefacing it with something, I've got some good ideas what's causing your headaches, but I'd be really interested to know what you yourself had been thinking might be going on here, or if you had any particular worries. And that's just a different way of eliciting it, but it's one of the big four criteria that on the whole the registrars don't do naturally when they join us in the training program. And this is number two of the big four. They tend not to go psychosocial. They treat more psychological problems as what's left in the wine glass when you've drunk most of it. In other words, just the dregs. When they've ruled out anything serious causing the chest pain, all you're left with is, well, maybe it's anxiety or stress, rather than having a much more proactive way of diagnosing a psychological problem and diagnosing anxiety. I've seen this many, many, many times in ECTV. There was a typical case where a patient, a young man, had some vague chest pains, but he kept on talking about his stress at work, his stress at home. And it was clearly, to my mind, very much an anxiety related, but we had all the ECGs, chest x-rays. And I asked the registrar later, what do you think was going on? And he said, well, I think he's very stressed, but that's not what he told the patient. What he told the patient is, we need to sort out your chest pain and get you back for all the results next week. And so it's a real skill to have that confidence to actually go with your gut feeling and think that something has either a purely psychosocial or at least a psychosocial issue is compounding a physical symptom. Missing cues. Again, I've seen this done. I was sitting with a registrar not that long ago where the middle-aged woman in her 50s with knee pain, but she mentioned 2 or 3 times that her husband had died last year. And she looked to me sad, and I just felt it in my bones that if the registrar had just asked, how's she coping? That's very sad that her husband had died, and why had he died maybe? I felt that she would have just burst into tears. But instead of that, we got the knee x-ray and the bloods and et cetera, and I just felt that was just, in a sense, that wasn't the main issue for that woman that day. Now, this is an important one, examination issues. In other words, they're just not doing proper examination. So a chest examination might be a quick listen through your shirt at both bases. And you think, oh, I don't think that's a proper GP examination of the chest. And I've talked to the registrars, why is that? Why, are you doing that kind of examination in hospital? And they say, yes. They're saying that that's the same examination that their consultant does. Partly in ED for privacy reasons, not exposing chest and things like that. But I think what they're missing is the fact that probably these patients may end up with a chest x-ray anyway, which may be why they're not bothering. And I know there's some COVID issues that have come into the equation as well now, but we're noticing that they're not doing proper chest examinations. The other issues that you can only really glean by sitting in and observing is that they may not actually be able to use an ophthalmoscope properly to see a disc. They may, and the other thing we notice is that their examinations are not focused. Someone comes in with a bit of vertigo and they're doing all the cranial nerves, but that takes forever. And they're not focusing their examination. So this is a really important one, I think, that when you're sitting in and you're observing, that you can actually see what's actually going on. What are their examination skills? When I look at their notes, really what I want to see, apart from that they're not too long, and I'd never knock those. I think that's something you learn as you get more experience to refine your note taking. And they, on the whole, our registrars write exemplary notes. But sometimes what's missing is the synthesis. So they've written a lot, but they haven't brought it together and put themselves on the line and written a differential diagnosis with their working diagnosis to the fore. And I think that's a discipline we need to help them with and teach them with. A poor structure to the consultation. You see many different problems arise here. Sometimes the registrar moves on to the second problem before they've really dealt with the first problem. They have to come back to the first problem. Sometimes if they're not sure what's going on, they cycle. They sort of take a history examination. They're not sure. They take another history, another examination. They go around in circles. So they've got problems with the structure. Cambridge Calgary, they talk a lot about the two halves of the consultation. The first half being the history and examination. The second half is when the patient comes to sit, gets stressed, sits down, and you say, right, what's going on and what are we going to do about it? And typically in a 10-minute consult, it's quite common that the split might be 8-2. In other words, very little time left for the explanation, for the decision-making, for the management, checking, understanding, safety netting, and follow-up. And they argue that we should try and make those a little bit more even. It's very difficult to be patient-centered, especially with the management, if there's only 2 or 3 minutes out of the 10 minutes allowed. So that means, therefore, trying to refine the history taking, doing a more focused examination to free up a bit of time later. Not coping with uncertainty, and I'm sure we all know exactly how often with over-testing, etc., and not using time as a way forward. It's a wonderful thing to do. Just use time and see how things go in general practice. Then there are time management issues. The registrars that keep running late, who have difficulty moving up from 2 to 3 to 4 consults an hour as they progress through their training. If you do have a registrar who is sort of really struggling and they're not writing their notes between consults and they've got all the notes to write up at the end of a very busy morning, that's another warning sign that they're having trouble with their time management. You've got to get in there because you've got to make a diagnosis. It could be multifactorial. They may be trying to deal with too many things in one consult. They may have a poor structure. They may be having difficulty with coping with uncertainty. Any number of reasons why their time management might be poor, and I think you need to observe it to help them with this. And then there's one of my particular favorite criteria, which is shared decision making. And it's very, very common that on the whole, what they've learned in hospital practice is to be quite doctor focused and quite dogmatic about the management. And that's fair enough with something serious. And absolutely, crushing chest pain, there's no point of doing shared decision making. But in general practice, quite often it's more nuanced. There is room for maneuver, and it's a skill they need to learn. So this is the third of the big four. And this is the fourth, not checking understanding, not actually bothering to actually check how much. And it's so much more time efficient to get the patient to quickly reflect back what their understanding of the plan is, rather than you or the registrar repeating over and over again what the plan is. And finally, how to end a consult. Some of the registrars do struggle with actually ending a consult, which isn't naturally ending with all the normal social cues of handing over the script or whatever it is. And I learned how to end consults in those situations by sitting in with 2 very, very experienced doctors. I sat in with lots and lots of established GPs when I was going through training. I deliberately did it. I sought them out and said, can I spend a morning with you? And one psychiatrist who used to manage these very needy and very distressed adolescents with eating disorders would just say after half an hour, we must stop for today. And it was a kindly done, and they all accepted it. The implication being in 2 weeks, they'd be able to take it up again. And then I sat with a professor of general practice, very renowned in the UK, who ended one consult I was sitting in on, and he just said, oh, bugger off, I've had enough of you for today. And the patient loved it. And I thought, wow, well, I've never done that. And occasionally I've used it very, very selectively myself. And as long as you pick the right patient, they don't mind if you're quite rude to them in that kind of way. Just quickly on shared decision making, the evidence in favor of shared decision making is now overwhelming, and much less medical legal issues, much better compliance and adherence with chronic disease management, less surgery, and fewer investigations. However, in order to learn shared decision making, they've got some unlearning to do, because in hospital, where it is a bit more directive and sometimes appropriately so, this is a bit like going to see a tennis coach and they change the grip on your racket, and it's very uncomfortable unlearning how you've done it for many, many years. And let's be clear, if we're talking about shared decision making, we're talking about situations of professional equipoise where if they saw 5 or 6 doctors, they might get 4 or 5 different managements. Some might manage that way. And what we're coming into is that the other 2 pillars, besides the evidence of evidence-based medicine, the other 2 pillars being your clinical expertise, and the third pillar being the patient's values and preferences. And this is much more subtle and nuanced in general practice, where you're incorporating all 3 facets of evidence-based medicine. And it's not an obvious emergency that really needs hospital admission by emergency transfer today. So if you're talking about shared decision making, you like to hear the fact that there are some options, there are some choices. And Gerard Connors was very kindly done a role play. And what he says when he gets to the management is, I think what we'll do here is this. And that's not shared decision making. The 2 experts in the room, refers to Tuckett's work, in which the doctor is the expert about disease, but the patient is the expert about the patient, about their sociocultural background, about their beliefs, about their previous experiences, their family experiences, and the rest of it. And in summary, I did some research on how you can teach shared decision making. It's a complex skill. Don't be hard on the registrars for not doing this. It took most supervisors I interviewed about 5 to 10 years to crack shared decision making. So what we should do is, with our registrars, just highlight this skill, and let them see you do it. Because they've got a lot of unlearning to do. And the other thing that's important is Larve Wenger's community of the practice, the culture in the practice. If they see other established GPs not sharing decision-making, it's very difficult for them to learn. Whereas if everyone else they sit in with is also sharing decision-making, that's how you acquire this skill.